Good afternoon, everybody, and welcome. I think everybody would like to keep the Stevie Wonder on, but we've got some work to do. My name is Steve Rothschild. I'm the president of Health and Medicine Policy Research Group, and I just want to welcome you all to this webinar today. It's very exciting to have all of you here. By way of background, I am, in addition to being president of Health and Medicine, I'm a family physician with over 35 years of work with the Latinx immigrant community on the near west side of Chicago. My day job is as a professor and chair of the Department of Family and Preventive Medicine at Rush Medical Center, but want to begin by noting that my comments today represent my own opinions, not those of my employer. A new paper in Health Affairs put our challenge pretty succinctly. It said, given the clear relationship between immigration and health and the stark expansion of immigration enforcement, healthcare institutions have an ethical responsibility to prioritize family health and well-being among people seeking our care. And obviously, a lot of you agree. Over 500 people registered for this webinar, and it's just pretty amazing. I want to thank the organizers, our own Health and Medicine Board member, Mildred Williamson, Policy Director, Wesley Eplin, Jim Floyd from Cook County, Sue Avila, and finally, our events coordinator, Leandra Carlisle. I also want to give a big shout out to our live Spanish interpreters, Catalina and Roberto, for making this presentation accessible for those who are non-English speaking. We are fortunate to be joined today by two outstanding speakers, Cook County Commissioner Alma Anaya and Attorney Carrie Chapman. Commissioner Anaya represents the 7th District of Cook County. She serves as the Vice Chair of the Health and Hospitals Committee of the Cook County Board of Commissioners. Among her other distinctions, she is the recipient of the Alfonso Garcia Robles recognition from UNAM, the National Autonomous University of Mexico, an award given for outstanding work favoring migrants internationally. Our second speaker will be Carrie Chapman, an attorney and the Deputy Executive Director of Programs and Policy with Legal Counsel for Health Justice. Ms. Chapman is also an adjunct professor at DePaul University School of Law, where she teaches poverty law. After their presentations, we'll have a 30-minute slot for Q&A and discussion. So as you think of questions, you can put those into the chat, and that's going to be monitored and fed back. Our three sponsors are, by way of housekeeping, if you are not seeing the slide, for Spanish audio, please select interpretation in the control settings at the bottom of your Zoom window and select Spanish. I see a lot of you introducing yourselves in the chat already, and if you're comfortable, name, pronouns, organization, and keep those questions coming. Next slide, Leandra. So in preparing for this presentation, we have assembled a list of resources, and if you scan that QR code in the lower right-hand corner, there will be a list of organizations and information for both immigrants and partner agencies, including Know Your Rights information, signage, guidance, and so on. So that'll be a tremendous resource, and we want to thank the Planning Committee for putting that together. Couple upcoming events. On February 26th, Georgetown Law has Healthcare Institutions Hippocratic Duty and Immigration Enforcement at noon. And you can use the QR code there to register for that event. And then finally, the Illinois Alliance for Welcoming Healthcare has an upcoming training the following day on February 27th at noon, entitled Creating a Welcoming Environment for All, a training for providers and administrators in healthcare settings. So while this will be recorded, if you have friends or colleagues, you can point them to these other resources as well to bring themselves up to speed. So our goals today are in 3 parts. Number 1, to provide you with some basic legal information on the legal rights, resources, and needed policy and procedures to protect immigrants and refugee populations. We want to raise awareness of the practical legal actions and necessary training that healthcare providers and staff should have. But in many ways, the most important goal, and one that we're really going to come back to at the end, is that we want everybody on the call to leave with one or two ideas that can be implemented wherever you are, wherever you work, that you can do to help advocate for improving the safety of immigrants seeking healthcare. Sometimes we just, health and medicine, our webinars and our workshops are about ideas and about thinking about what we could do. This one, we want to be really action focused because we're at a time that really calls for urgent action. So in thinking about those three goals, I do want to begin with a caveat and with some awareness. We're holding this discussion at a time in which all of us face direct attacks on civil liberties and human rights. The right has deployed disruptors and spies, as well as individuals who will seek to quote us out of context or take names of attendees. I want you to know we have screened the registrations to reduce the risk of this, but we may have missed some. I want to really urge you that you take care of yourself. If at any time you're feeling uncomfortable, take care of your needs. If needed, log off. If you want to turn your camera off, that's fine. We will be monitoring the situation throughout the webinar. I want to really encourage you to prioritize your own safety and comfort as well. So very briefly, I was asked to say a few words about my own institution's response to the current situation. We aren't the gold standard. We're not the best in class by any means, but I do want to share it as a positive example of what healthcare institutions can do. This work for us didn't begin in January at the inauguration. It goes back to Trump 1.0 in 2017. There was an ethical will by the institution to continue to be a welcoming institution, but we realized that wasn't enough. There was a need for people to do the actual work of drafting policies and then implementing them. A multidisciplinary immigrant rights work group began to meet to ensure that we were providing that environment, ensuring ethical and culturally aware treatment of everyone, and also to support DACA students and residents on our campus. Surveys were conducted, they identified the need for staff education, and so programs were held to develop increased awareness of the need for inclusive policies that treated all patients respectfully. Out of that awareness, new things came to the fore. For example, during the first days of COVID, nurses noted that there were fewer timely updates of the families of immigrants in the COVID ICU than there were for non-immigrant families. So interpreter services were stepped up. Staff were made aware of the need to go out of their, go the extra mile to make sure families were communicated with. So it was an awareness, it was a cultural commitment, it was a values decision. At that time, we had policies written to address any efforts by ICE to come into our clinics, our hospital, or our colleges, but they were never put to the test. As we will hear today, however, by the executive order last month, the Trump administration has withdrawn protected status from schools, churches, clinics, and hospitals. In response, we have redistributed the policy that was written several years ago, making, in particular, our security staff and our frontline staff aware of rights and responsibilities. They are aware that if ICE or the police department presents to any location on campus, they must present a warrant signed by a judge, at which time they know that they have to immediately contact their supervisor, which gets them to the on-call legal counsel to review the warrant. Legal counsel for us has advised us that most of the documents that ICE will present are not legally binding warrants. They have not been signed by a judge, and so we should not be allowing any questions, we should not be answering questions or allowing officers into any clinical areas until the papers have been approved and the status has been reviewed. In the meantime, patients will be escorted into secured clinical areas and any papers with names on them will be put out of sight. The message we have implemented throughout the hospital, beginning with the top of the organization, is that we'll follow the law to the letter, but we are going to make sure that our patients are safe and that we adhere to the law, which includes HIPAA and the protection of confidentiality and rights. Without a warrant, ICE and CPD have no business on our campuses. All that said, I want to keep things real. Hospitals are under threat, and should the Trump administration impose penalties such as withholding Medicare and other federal funding, that could threaten the survival of any organization. As a result, we can already see that some hospitals are scrubbing references to DEI, they're stopping gender affirming care, and they're trying to keep their heads down so not to become the first target. But where I think we can be doing better is by not doing the government's work for it. We shouldn't be changing our missions. We shouldn't be withholding services to anyone. We need to continue to put patients first. So our hope of this webinar is that this provides you with the tools to strengthen, to support the care of immigrants and refugees here in Chicago and in the surrounding communities. With that, I want to turn things over to Commissioner Anaya. Commissioner, the floor is yours.
Thank you so much, Steve. Appreciate the context that you've provided us. Hi, good afternoon, everyone. And again, I want to thank the Health and Medicine Policy Research Group for the invitation. I'm extremely grateful to be amongst great colleagues in the work here today as we discuss particularly a very interesting and devastating time. We know that health organizations play a key role in protecting and sustaining immigrant communities. And I'm quite honored at the moment to be able to address today this issue, and extremely grateful again for being a part of this webinar to see how we can deepen our impact. Again, my name is Alma Anaya. I am the Cook County Commissioner of the 7th District. It represents the southwest side of the city of Chicago, communities like Pilsen, Little Village, Bryant Park, Back of the Yards, and many other predominantly immigrant, Latino, and working class communities. I am currently the only Latina serving on the county board and one of the first formerly undocumented immigrants to hold office in the country. And yes, like I was mentioned earlier, I'm very proud to serve as the Vice Chair of the Health and Hospitals Committee in the county, and also proud to have a very robust and active 7th District Health Task Force in which we discuss a lot of these issues and have continued to convene many folks from the Southwest and the city of Chicago in regards to health issues. So many of the organizations today that are here present provide essential health services to my constituents. These include patients who are uninsured and underinsured, and some that in many cases would not be able to have access to adequate health care if they weren't there. So I know that you all are very especially important and have stepped up in many occasions, including during the COVID times, to protect communities by providing life-saving information, vaccinations, and access to care that address the long-term effects of the pandemic and beyond. So today we're asking, obviously, once again, and we're discussing how to be able to meet the moment and how to be able to protect immigrant communities from the threats and attacks of the current administration, but as well as some of the challenges that come with limitation of potential elimination of services and funds for immigrant efforts and healthcare efforts, both again at the federal level and at the state level. We know that immigrant rights are essential to health equity. And while the current political landscape threatens our well-being, we know that Cook County and Cook County government, we stand firm in protecting and fighting for the most vulnerable residents. As a matter of fact, Cook County has a long history of being able to do that, both on the government side and also on the healthcare side. For example, Cook County has in place the ICE detainer ordinance that was passed in 2011 that prohibits the sheriff's office from cooperating with ICE authorities absent of a criminal warrant. This guarantees that patients who may fear being stopped by a sheriff vehicle from them, on their way potentially to a doctor's appointment, from them not being able to automatically be transferred into immigration custody. The ICIRR ordinance is significant because of one thing. Oftentimes I get asked about sanctuary policies and whether, they're impactful. And it really does prevent, county resources from going and being used for immigration enforcement activities. And it also limits, staff being used and physical spaces and clinics being used for immigration officials. And this protection has been extended, and I know that there's a commitment for not only within the sheriff's office, but throughout other offices. And I think we're working very diligently to expand that to every clinic and every one of our facilities, including some of the courthouses. So I'm not sure how familiar everybody is with Cook County Health, but I just want to kind of reiterate that Cook County Health is the county's largest safety net hospital and system. And I know, we are trying to work as hard as possible to remain committed to providing all patients with health care, regardless of their immigration status or their ability to pay. We have started many efforts such as like training. I know that we're trying to make sure that all Cook County Health staff are trained. And I, again, want to uplift you all as well, because you've been a part of the conversations and how to be able to perfect that and how to be able to ensure that the policies that, Steve, you mentioned are continuing and that they're part of our internal policies here in Cook County, and that we continue with that mission of protecting all patients that come to us. We know that, Cook County Health has done other efforts to being able to kind of support helping everyone that is coming in. And this includes increasing their capacity to offer more virtual visits through Express Care, covering, basic health issues for both adults and children. We've expanded behavioral health efforts and grants to our partners. And then we've also done things for folks that do not have insurance or cannot or do not qualify for Medicaid or Medicare, including an effort that was passed by helped pass by my predecessor called CareLink, which is a free program that helps Cook County residents cover the cost of care of any of the Cook County health facilities. And this includes the primary care visits, lab tests, and emergency visits. CareLink is available to anybody regardless of their immigration status. As a matter of fact, it's a program that we want to make sure that folks know about so that people do not have that fear. I think a very important thing that I also want to uplift at this moment is how to make sure that we know, all of us, right? Not only folks that have been in the trenches during this really difficult time, but I think everyone, including, promotoras and other folks that have been very active, including elected officials, the fact that, we do have this responsibility to step up and really meet the moment, and it's going to take all of us. So we know that since the election, we've heard a great fear and worries from constituents and also partners in the work for knowing what to do. And it's fear that we're seeing from everyone, including, mothers who are not sure whether they should send their children to school, or families who do not really understand, maybe not being able to leave their home or having that fear, and having to really prepare for worst case scenarios, which is extremely devastating. We've also heard of residents that are canceling their doctor appointments because of the fear that they may have from, encountering ICE or driving or being able to in any way be put in a situation. And this is quite devastating. But I also want to, uplift the worst case scenarios in these cases. And I was quite disheartened by hearing of the devastating news from a young child, Jocelyn Rojo Carranza from Texas, who just a few days ago, we've learned that committed suicide from the great behavioral strength stress that it caused the bullying that was happening to her and her family. This was a child that had reported being harassed by other children and bullied for the immigration status of their family. And this caused great mental health toll to her, to a point that she decided that she couldn't live in these circumstances. And that really breaks my heart, and it really chokes me up a lot, because I was an undocumented child myself and cannot even understand the heavy burden that is actually put on our children and our families at this moment. So healthcare is not a priority. Mental health is not, it doesn't become a priority because your priority is just being with your mother, being with your siblings or with your father. And that is something that I think all of us need to really think about and really figure out how to be able to step up. And I want to share something as well from a great mentor, because I think at this point, we are all trying to figure out what to do. We're all trying to figure out how to uh, really leverage what we're living, but figure out how to turn that into action. And one of my great mentors, Mr. Ronald Muskin, we often talk on the phone. And just a few weeks ago, I was sharing with him my frustration, my rage, my fears, and quite honestly, the hopelessness that I really feel in this moment when everything is being attacked. And, he turned what I said and said, Alma, we have been preparing for this moment all of our lives. And quite often that seems like such a simple, thing, but he went on to explain to me that everything that we've been doing, the position in which we're in, the relationships that we have built, have been what we have to now tap into to really channel that and be able to be really powerful vessels of change. And yes, it is very frustrating, and yes, it is very difficult to try to get through this. And I think at this moment, channeling our networks, channeling each other is the best thing that we can do. So we will continue to channel the frustration, and we will continue to protect constitutional rights and the human rights of our residents. We will continue to ensure that we're resisting and providing access to health care. I know that at this moment, we will channel that and be able to kind of come from that, and very much like a phoenix, be able to kind of rise. So I encourage everyone joining today to stay informed of what's going on, to create unity, to ensure that we're creating that partnership with non-for-profits, with academia leadership, with elected officials, with local schools, with residents, so that folks understand that we have each other and that we're able to protect each other. Because at this moment, so many lives depend on it. And we need to ensure that we're standing up for the communities and the most vulnerable individuals that we encounter through our day-to-day. And it is quite critical for us to be able to do that and to channel each other in this. So again, I thank you very much for the invitation, and thank you for your commitment. This is not easy work. It's quite difficult, especially in a place in which we're also having to deal with potential family members and others who have mixed status households, or maybe our clients that we deal with every single day, or ourselves. So I think it's extremely important at this moment for you all to, yes, like it was mentioned, take time for yourself and really be able to channel that frustration, like I mentioned earlier, and stand strong for one another. Thank you.
Thank you, Commissioner. It is so important that we stand together with each other. We will all have days when we feel beaten down and the energy is flagging, but we will also derive strength from each other. I know that Commissioner and I has to, I believe, sign off at 5. But we will keep track of questions in the meantime. Let me at this point reintroduce Carrie Chapman, Deputy Executive Director of Programs and Policy at the Legal Council for Health Justice, to talk to us about what we can do and our rights and responsibilities. Ms. Chapman.
Hey, everybody. So I'm Carrie Chapman. I use she, her pronouns, and I work at the Legal Council for Health Justice. And just super briefly to explain what that is. So we're a small organization that provides free civil legal services to low-income folks. And we focus those services on getting people access to health coverage and health care. And so I would say that in general, my background is a Medicaid nerd. I love the Medicaid program, and I am deep in the weeds on the Medicaid program. I don't practice immigration law, but I do practice sort of at the intersection of public benefits and immigration. So I do know a lot, sadly, from Trump 1.0 about the ways in which public benefits, access to healthcare, and health coverage intersect with our current immigration rules. So I'm going to try to share my screen. I had a Zoom debacle this week, so I'm sadly a little worried about that. And let me get to slideshow. The other thing is I have multiple screens, so you're seeing the presenter view, you guys, and such is life. So you're seeing my view on the slides. So I'm going to talk about creating a welcoming environment for all, and ways in which all of us can make sure that people feel safe and comfortable coming to our institutions for getting healthcare. And I really want to give a shout out to the Illinois Alliance for Welcoming Healthcare, which I'll talk a little bit more about later, a great group of advocates and healthcare providers, and also to the Illinois Coalition for Immigrant and Refugee Rights, also known as ICIRR, for all the work that we've collaborated on in the gathering of ideas for welcoming healthcare. So the very first thing I want to say, and maybe the only thing that I really want you guys to take away, is that we are in a moment where it is critical that we not submit in advance to threats that aren't actually legally real, right? The administration is expecting that we will submit in advance. And once you start down that road, it gets very, very difficult to dig yourself out. So right now, we have to say absolutely no. This is morally abhorrent. This is, against our values, and we do not agree, and we do not submit. And there is a small window of time for us to really draw that line in the sand, and it is right now. So I'm going to try to have that be kind of a frame for the discussion today. So I'm going to talk a little bit about this sensitive locations memo that Steve talked about at the beginning of the call. I'm going to talk about some model policies and practices that the Alliance for Welcoming Healthcare and ICIRR and the Shriver Center and I sort of pulled together from both what we know and what people are talking about around the country, and we're talking about since 2017. To see what healthcare institutions can do to be welcoming to their immigrant community patients, some best practices, and then again, doing Q&A. And I just want to say huge congratulations to a lot of the healthcare associations and professional associations who have stood really strong right now and firm in saying that patient care is their primary responsibility. And they are not responsible for immigration law or the enforcement of immigration law in the United States of America, and their moral, ethical, and professional obligations are to their patients. And I think we need to keep saying that over and over and loud. So starting in 2011, there have been guidances and memos from the Department of Homeland Security indicating that ICE should not prioritize enforcement at sensitive locations. And what that means is that there's not a statute, there's not a law, there's not a federal law, and there's not even a federal regulation, which is also law. But there were guidance and suggestions and memos from the agency that said, we're going to deprioritize enforcement at places like schools and churches and hospitals. And that memo was strengthened by the Biden administration And that memo has been rescinded by the Trump administration. What I want to be clear about is that this is more about optics and culture than it is about law. So the sensitive location memo always had exceptions, and it had several exceptions. So it didn't actually say no enforcement in these places. It said enforcement was disfavored, and here were the things that you had to do if you wanted to do enforcement at those locations. And the 2011 memo said you have to do all these things, and the Biden administration memo made the hurdles even higher. But it didn't make it impossible. We've never had safety, complete safety at these institutions. What pulling the memo means is a culture change, so that instead of agreeing that there are places where people should be allowed to be safely and without fear of law enforcement engagement, that we're no longer going to value that. We're going to say that we don't think that that's true anymore. And it's an important culture shift, but it's not a particularly important legal shift. There was always a workaround. And I also think it's important to understand that I always want to put ICE enforcement in the context of all law enforcement, right? Because from my perspective, it is true that I don't want any law enforcement happening in sensitive locations, but it does all the time. And so there was a protection specifically on ICE that didn't apply to other kinds of law enforcement. And I think it's really important for us to understand that we need to put ICE and other law enforcement in the same bucket. And we need to think about how we do law enforcement in this country, not only because that's right and just, but also because it builds bridges with communities that are subject now to being targeted and communities that have been targeted for decades and decades and decades with inappropriate, overly robust law enforcement. And to all be able to come together and set boundaries makes us much stronger than dividing us on this point. So a lot of optics in removing this sensitive locations memo, not so much legal implications. So what is still important to understand is that regardless of a sensitive locations memo, there are constitutional limits on law enforcement and on ICE law enforcement. And those include Fourth Amendment rights to privacy, which I'm going to talk about more, and whether those you get a right to privacy depends upon how public the area you are in. And the requirement of a warrant if you are going to search a non-public place in order to get data on someone or arrest someone. So nothing has changed so far about the US Constitution in the removal of the sensitive location memo. Again, it's a culture shift and one I hate, but it is much more a culture shift and much less a legal shift. So can ICE make arrests in my facility? Sure. And so can CPD, but there are limits on that. So if they want to enter a non-public area to make an arrest, then they have to have a judicial warrant or your institution's consent. And those are necessary for them to make a lawful arrest, an arrest that will stick at your facility. So can they? Yes. Are there limits on that? Yes. And again, I'm going to keep talking about this for sure. The Fourth Amendment protects all individuals, regardless of their immigration status, from unreasonable searches and seizures. The Fifth Amendment of the Constitution ensures the right to remain silent when confronted by law enforcement. And these two rights are always a part of sort of know your rights cards and know your rights training and information. And so one of the things that, Steve talked about at the beginning is, having your institution and playing a role in your institution, helping people understand their rights. Because if people understand their rights and exercise them, that is also power. And so lots and lots of resources in all kinds of places. I've got some in the slide deck about know your rights information, definitely something we need to be spreading far and wide. I also would say that these rights apply to everyone in the United States. And so to the extent that we have been lax in requiring entities like the Chicago Police Department to respect these rights, if we want to live in a society that is free from overly aggressive police enforcement, law enforcement overall, we need to enforce these rights for everyone. And that means educating people about their rights. So again, knowledge is power, because knowledge allows you to act in a way that protects you as the patient and as the healthcare provider to protect your patients. And so that's what I'm going to talk about in more detail. So the idea behind the model policy is to have, to suggest to healthcare entities what policies are that will telegraph to their patients, we are trying to be as safe a place as we can be. We care about you. We want you to get healthcare, and we want you to get healthcare here. And we are making an effort to be a safe place for you. So exactly the policies that are going to be appropriate for your institution are going to vary. And that's something that you guys as members of the institution can ask about and insist on, and, you know, make sure that it's being paid attention to and it's being implemented. But from my perspective, I'm not providing legal advice to institutions, but to say doing these things and then communicating to community that you're doing these things means that you feel like a safe place for people to interact with. And really, kind of unsurprisingly, because a lot of this stuff has been floating around, right? The key idea is to have people who are responsible for law enforcement interaction. So the people who are actually responsible for doing the interaction. And then to have your frontline staff, whoever that is, trained on how to get to those folks, right? So how do I get to the people who can navigate this interaction with law enforcement that I'm facing as, you know, a frontline intake worker, as a security person, et cetera? So to make sure that everybody on the front line knows who to contact, and then everybody who's a contact knows what to do. And really, everybody can benefit from some basic training. So if your institution has done a really good job training frontline staff, but everybody else feels sort of clueless, then it may be something to ask for, to say, can we all get some just really basic training on what the policies are? Can you share them? Or can you do an oral training if you don't want to share them? So that we all feel confident that we know what's supposed to happen. And to the extent that we're somehow engaging with it, we know what the rules are. And so sometimes I think frontline staff are getting trained, which is fantastic, but other staff are a little bit clueless. And so really institution-wide being like, here's our policy and practices, even if you may not be touching this much. So another key takeaway that I think is important for all of us to reflect on, even my agency, right, is that you cannot be forced to divulge information you don't have. If you don't have it, then it doesn't matter if there's a warrant or a subpoena or anything else. If you don't have information, then you can't be forced to share it. So thinking about ways in which people's immigration status might be memorialized anywhere, in electronic medical records, in anything in writing, do we need to have it? Are we documenting things that we should not document? Because again, the protections that we have are not completely limitless. They're not endless protections. They can be pierced by a subpoena or a warrant. So don't collect what you don't need. And that creates a little bit of a tension, right? Because it may be that patients are eligible for benefits programs, or a U.S. citizen member of a mixed status household is eligible for a benefit program, but that requires getting information from that person. And so really reflecting and thinking about those conversations and revisiting the scripts you have for those conversations and the way you're going about those conversations and the training that the people who are having those conversations have, so that people feel as comfortable with their choice to share information or not share information, to apply for a program or not apply for a program as possible. For most public benefits programs that, let's say, for example, a U.S. citizen child in a mixed status household has, for most of those programs, there are a fair amount of protections for the information that is given. But that protection is not perfect. I cannot say definitively that every bit of information that is shared to apply a U.S. citizen child for Medicaid will never, ever be in the hands of ICE. I think it's very unlikely because it's a very cumbersome way to do immigration enforcement, to sort of try to mine massive databases for bits of information about mixed status households. There's a lot faster and easier ways to do immigration enforcement. But I think it is important for us to be honest with folks that there is a non-zero chance of that privacy being pierced, and that really the question is to make a decision for your family about the value of the benefits versus what I believe is the low risk of it being shared for immigration purposes, but non-zero risk. And also being sure that your institution has a culture of understanding that everyone's job there is to provide care and not to engage in law enforcement. And I know that sometimes that can be a little bit challenging because there is a fair amount of support in this country for, you know, kind of relatively vigorous immigration enforcement. I think one of the ways to address that tension is to talk about dealing with law enforcement generally. As I said previously, right? We want everyone to feel safe here and comfortable here, and everyone who comes here for care to be treated respectfully and not to be turned over to law enforcement if it's not legally required. And that can go a certain amount of the way. And then also to say, as I'm about to talk about, you know, that releasing information about people could be a violation of federal law and put our institution in jeopardy. And so it's a condition of your employment that you follow our policies and procedures around federal law. So kind of a carrot and a stick there. So obviously having a sort of policy overall that the institution is not going to provide information to law enforcement except as required by law. So taking that as your starting point. There may be circumstances in which we are required by law to provide information, but we don't consent to anything outside of the circumstances in which we have to. We don't consent to the release of information, period. Sometimes we have to release information. And then some of this best practice, right, is just what you would expect. It's traditional sort of HIPAA best practice. Don't leave stuff lying around where people can see, you know, do reflect again on patient privacy and how you are protecting it. Because again, the best practice for following federal law, for following HIPAA, is also good practice for protecting immigrant patients. And again, contextualizing this as not, we are taking a specific group and giving them special protections, but our patients are our patients and they all get protection because we are a healthcare institution. We are not law enforcement, right? This is something that we do for everyone. This is not, you know, we don't, isolate a group and give them extra because that is something that people are very touchy about right now. And this is a clear opportunity for us to say, nope, everybody, we protect everybody. This is just about best practice for protecting everyone. I don't want my information shown to law enforcement either. Okay. So again, If a patient asks, is their information safe? Important to say, there are circumstances in which, for example, we might be a mandated reporter, like making sure people are informed about that, because you don't want to say, of course it's safe, when in fact, the person is speaking with a mandated child abuse reporter. Talking about the institution's policy of not releasing information unless they're required to do so by a court of law. So are there exceptions to privacy? Yes. Do they have to come from a court of law? Yes, they do. We won't just offer it up. We're not turning over your information for grants or other things, right, that might not have protection. We're not turning over your personal information. Again, on public benefits, I think it's fair to say, I think your information is generally safe, and that the value of the benefit program for, let's say, your child is really important. And I don't think that immigration enforcement is going to be, trying to mine the Illinois Medicaid database. But am I 100% sure that that wall will never be pierced? No, I am not 100% sure. I think a lot of folks are concerned about the law related to public charge. So this idea of that if you are a public charge, you can't get your green card, which has become, it's a very technical law, and in community, it gets sort of imagined very expansively. Understandably, it's intended to make people afraid, and it does. But generally speaking, no. Seeking Medicaid or Medicaid-like programs or health services are not grounds for deportation. They will not stop you from getting a green card, et cetera. And so I think it's important to help people understand that the state of the law right now is that use of these programs will not lead either to you being deported because you've used the program, or to not being able to adjust your status and get your green card. What will happen in the future, I do not know, but this is the state of the law now. So, as I said, the Fourth Amendment protects individuals from improper searches and seizures, but it only protects private areas. You have to have a reasonable expectation of privacy to have Fourth Amendment rights against search and seizure without a warrant. So the most private place is your house, but a general public institution can in fact have private areas. And so those are areas in which no law enforcement can enter without a warrant. But they have to actually be private. So signage is great, but signage with no actual barrier for the public just walking in past the sign point is not going to pass muster, right? A court of law is going to say, well, you didn't actually create enforcement. So there needs to be some kind of restriction to entry in order for you to call a space private. And so if you need to have an appointment, if you need to be with somebody with an appointment, if you need to, have a connection with an inpatient person to get past a point, then past that point is private, and in front of that point is not. And different areas are going to be different, right? Your main entrance and perhaps your main waiting area may not be private. If you're not going to screen everybody at the door to that area, it is not private, and no one has Fourth Amendment rights in it. Your parking lot, probably not private as a practical matter, unless there's a security guard and you can't enter the parking lot unless you can explain your business with the institution, and that business is healthcare. The model policies go through protocols for all kinds of contacts. So this slide, and you'll get these slides, talks about, staff or email, phone calls or email to staff. That's really the easiest thing, to just then redirect law enforcement to the designated person. But it's if immigration comes on site that I think everybody's sort of concerned about. And what I would say overall is it's important to practice this, right? You guys in healthcare are fantastic at doing like drills and mock-ups of things. The lawyers do this too, right? Practice what happens. Have people pretend to be, law enforcement and be aggressive and, pretend to be armed and in like full tech gear and shouting at you, and figuring out, okay, so what are we going to do? These are the people that we call. You can have, if your institution has like a code system over an intercom, you can have a code for ICE is on the premises. And you can make sure that you are protecting patients and protecting information even more. Everybody can be trained on that code. But whatever the protocols are at your organization, you got to practice them. If you don't practice them, then when somebody shows up with a semi-automatic weapon and starts screaming in your face about turn stuff over, it's going to be very difficult to interact. So I just put in here a couple of different scripts for scenarios. If you see an unidentified, police officer, here's an actual script. Can I get your name and badge number? This area is restricted to patients and staff, and we do not consent to law enforcement being present here without a valid warrant. Give people scripts. This is going to be a very stressful engagement. People need to know what to say, or they need to be able to look up the script someplace. And there are just a couple more scripts here. Patient X has not consented to disclosing their protected health information. I can't do it. Do you have a warrant? Here's who you can talk to. And escorting law enforcement as much as possible to either outside or to a secluded place so that they're not in contact with other patients while you're having this interaction. Again, lots of places don't have a code system, but if you do, think about an ICE code. And then what do you do? If you have the ICE code, what happens? Like, what are staff doing when they hear that code? And then really importantly, and again, I think a lot of you guys have heard about this, there are two kinds of warrants that ICE in particular might show up with. Like CPD isn't really going to do this, but ICE might show up with either a judicial warrant or an administrative warrant. And an administrative warrant is just a please. And a judicial warrant is an order by a court. And under HIPAA, you have to comply with a judicial warrant. And so it's important for people to be trained on the distinction between the two. But you can, under immigration law, you can consent to an administrative warrant. And it's my perspective that healthcare institutions should never consent to an administrative warrant. HIPAA doesn't require you to consent to an administrative warrant. And in fact, I think consenting to an administrative warrant could be a violation of HIPAA, something for your general counsel's office to look at. But a judicial warrant is very specific. It names a specific person or specific documents. If it's a subpoena, it references a specific case. It should be specific about the date and exactly what they're looking for. And it has to be signed by a judge. So you're going to see like a case header on the top of the warrant. And it needs to be signed by a judge, which means not just a signature line for a judge. There needs to be an actual signature on it, and it needs to be a relevant date. And again, you're not asking your frontline workers to look at two different pieces of paper and determine which is which, right? It's the liaison that's doing this, but I'm just giving everybody a little bit of information so you understand as these things are talked about that there's two different things. And here's an example of an administrative warrant. If the document does not grant access, if there's something wrong with the warrant or it's an administrative warrant, then I would hope that people's position is we don't comply. We don't give consent. Either because morally and values-wise we disagree with it, or because we think that consenting might be a violation of HIPAA, and I think it might. Don't give consent. And then saying to your staff and to your patients, we don't consent to giving information to law enforcement unless they have a court order. And again, we do this with CPD. We don't hand out your information to CPD. We protect everybody here. This is a safe space. And again, I think you have the cover of HIPAA to say we can't just willy-nilly give this away. So if in fact you have employees who are like, well, what if I want to cooperate? It's like, well, here's the thing. There's HIPAA, and you don't get to violate that in any circumstances, and certainly not to act out your political beliefs about immigration in this country. Not your job. And again, role play, role play, role play, role play. and lots of resources. So again, I will send out all of these resources. They seem like a whole lot, but there's a ton out there. And this is a whole other page. I partly put all of these resources in here to reinforce my first point, which is do not submit to something you are not required to submit to just out of fear, right? Don't do that. If in fact the federal government starts tinkering around with federal funding, they are still bound by the US Constitution if we force them to be bound by the US Constitution, right? So they may be able to hinge funding on certain kinds of activities, but they cannot hinge funding on you consenting to a violation of the Constitution. That is not allowed. They cannot say, we won't give you Medicaid money unless you violate your patient's Fourth Amendment rights. That is not a quid pro quo that they can give us. They might say, you can't use our funding to serve people without status, but they can't hinge your funding on forcing you to violate the Constitution. And we have to hold that line, right? Because if we pre-enforce that, then it doesn't matter that there's a Constitution. We are all right now deputized as officers of the US Constitution. We have all just taken an oath to uphold it. And so we need to make sure that everyone can protect the rule of law. And we protect the rule of law by not submitting in advance. And again, your institution is going to say, we could lose federal funding. But it's important to make a distinction between there could be a federal rule that affects our funding, and it is okay for the federal government to insist on a violation of people's constitutional rights. Those two things are not the same. Don't conflate them, and don't let your institution conflate them. And again, lots of resources. All right, stopping sharing. Oh, 501. Y'all, that's like a miracle.
That was perfect. That was fire. That was just awesome, Carrie. Thank you so much, and Commissioner. We have been deputized. We will not consent and submit in advance. And with that, we will open up to questions. There have been some questions in the Q&A. Should I start there? How do you want to do this, Leandra?
Yeah, we can start there. And then there were some questions sent in advance, and I can also address those. I'm seeing two questions in the Q&A.
Yeah.
Okay, just making sure I'm not missing any.
No, I only see that there were some earlier ones, but I think maybe they were answered. But
okay.
But we
so
have
any suggestions for how medical students can stand up for immigrants' rights in health settings, rural Texas, where most, if not all, colleagues have openly denounced? So one thing I'll say is that there's a number of different communities that ain't too fond of law enforcement, right? Like Waco, Texas. So, and federal law enforcement. So you can oftentimes find common ground if you say, you know what, this isn't actually about immigrants. This is about overstepping of the federal government. And so trying to find frames that reach everybody can help. And then relying on HIPAA. Here's the thing, HIPAA says we can't share this information. It's actionable if we share it. We have to follow federal law. This is, they're, two competing federal interests, but one of them directly binds us. So this isn't about your own personal thing. I do not know the details about the NYU situation, not to protect undocumented patients from ICE. I really don't want to speak to something I don't know anything about. It is in fact true that there is going to be very little you can do if ICE shows up with a judicial warrant for a patient in your care. Like, it just is. A couple of other questions that people asked that I think are really important. Guardrails to protect data that discloses documentation status. Don't keep it. y'all, don't keep it. Don't put it anywhere. If you have it, then somebody can probably ask for it. I mean, they may have to go through a court process, but they can ask for it. Try to get it out of your EMR, or at least don't collect it going forward. And lots of institutions have done that. I've worked with a number of institutions that really work hard not to put anything about status in their EMR. And so that's my best advice, is that you cannot disgorge what you don't have. There are, in the resources, there are steps to take if somebody is arrested by ICE. But one thing that you can potentially do is figure out ways that you can alert the patient's emergency contact, because if the patient isn't with anybody and they get picked up with a judicial warrant, then you can help connect their emergency contact and say, like, this person was picked up, and then there's information for that emergency contact to try to find the person. So figure out what policies you need in place and what consents you need to get from patients to use those emergency contacts. That's hugely helpful, so that somebody just doesn't have their family member come home from an appointment and not know what happens. If someone's been deported when they were young and came back and have been living and working, it's going to be very challenging for somebody who has previously been deported. It's a hard case to make to protect them in the future. Again, there are going to be we're going to lose some things, you guys. Like, bad things are going to happen. We're not going to mitigate 100% of the harm. We can't have we can't have a win be 100% mitigation. That's not a win, right? Smaller wins. We're going to have to have smaller wins than that. How do we update the public on things we don't have answers for at the time? You know what I would say is, like, you have great skills at this, right? Like, people have medical situations that we don't have answers to. What do you say to them? How do you talk to them about something where you're like, I don't really know what's going on. None of the things the diagnoses I think were correct, or we don't understand that much about this disease or whatever. Like, you have good practice communicating hard things with unknowns to patients. Use the same skill set. You guys are great at this. You have these conversations every day. It's the same skill set. How is Medicaid eligibility affected by kids being separated from parents? So U.S. citizen kid, let's say parent is removed. Not at all. Kid still is Medicaid eligible. So no concern. Now, do you have someone who can consent for medical care for the minor? Oh, that's a little bit trickier, right? You might not. So they might still have Medicaid eligibility, but you don't have an adult consenting. So having some plans for that and making sure your institution is prepared for that. And then talking to folks about, safety planning and emergency planning for families. Now, this is a horrifying thing to do as a healthcare worker, and a horrifying conversation to have as a person, to talk about. I mean, my kids are adults, but honestly, I can't imagine having a conversation with somebody about what happens if I disappear from you, and who knows if we'll ever be reunited. Like, I don't even know how to get through that conversation, I'm going to be honest. But if you have relationships with folks and long-term treatment relationships, and there's trust there, then, saying, like, have you done some emergency planning? Because then you can designate a short-term guardian for a child, and that person will have medical decision-making authority and can help make sure that the Medicaid stays on, et cetera. So those emergency planning documents can be really, really valuable to families. But I caution us all to have those conversations really carefully and thoughtfully. And if you have a very brief interaction with somebody, I really wouldn't say, like, let's do some safety planning. Like, this is a very intimate conversation. So I think it's super important to be thoughtful about that. There's a great toolkit, and I put it in the resources specifically for EDs, for emergency departments. And so there's lots of good information out there, because there's a lot of coming and going in EDs. And so it's a link in the toolkit. Do you know of legal organizations that are providing review of institutional protocols for organizations? So no, in the sense that organizations like mine don't have institutional clients. We serve individuals, but I'm happy to connect smaller institutions that don't have in-house counsel with potential pro bono resources, so free legal resources at a firm that does this. Like, I'm happy to try to make sure that we've got firms working with smaller organizations. Now, they're working for a big organization, right? They're not going to provide their services for free to Rush, who doesn't need them because they have their lawyers. But you know what I mean? Like, so, but smaller community-based organizations, small clinics that are worried, those folks, I'd be happy to try to make sure that they're connected with free legal resources, but it isn't going to be folks like me. It's going to be big law firms that do this for a living, which I do not. My focus here is on helping patients feel safe, and telegraphing to your patients that they're safe as they can be with you, not on like actually what, you know, HIPAA requires. And I think that's sort of the highlights of and then there's more Q&A. All right.
And there was a question earlier, so it kind of fell into the answered category.
Oh, okay.
About community health workers or promotoras. Health and Medicine does a lot of work advancing community health work, and it's sort of an interesting zone, especially when promotoras are going into people's homes. What kind of collaboration they can be doing, how they can be helping, and so on.
Yeah. So first of all, you know, having know your rights information for folks. Here's when you have to open the door. Here's when you don't have to open the door. Here's how you do this interaction. Here's the phone number you call if somebody is picked up by ICE. And just saying, like, here is a bunch of information that at least gives you a little bit of a sense of control over your situation. Doing that safety planning, getting those documents. Where's the kid's birth certificate? You know, is the parent's goal to have the child stay in the US if the parents are removed, or join the parents in another country? You know, does the kid have a passport? What are the rules for joining the parent in the other country? You know, what is the intention of the family? And I think promotores are great folks to have those really hard conversations, because you have a really good relationship, right? You have the intimacy with somebody to have that conversation. So I definitely think that there are huge things that promotores can do. Hopefully you're not actually engaging with law enforcement, holy moly, but I'm really hopeful not. Some questionnaires paperwork automatically ask about like immigration status, you know, definitely saying, you know, like, just don't answer about your status, right? And if somebody comes back to you and says they need it, then why? And then really auditing within your institutions. When are we asking? Why are we asking? And how are we documenting it? And you may find that you guys are doing a fabulous job. Like this is not our first rodeo. So don't assume that your institution's doing badly. But I think, again, as all of us have to enforce the US Constitution, all of us have to make sure like we're touching different pieces of the giant elephant that is healthcare, right? So like double check, like, let me look at my screens. Like I did that recently with our intake system. I was like, what do we ask about immigration in our intake system? We have protections like HIPAA, right? Attorney-client privilege, very hard to pierce. But I'm like, what do we have in our system? And all of us can do that. We can do little audits in our own life.
Even if I was going to say, even for people on the call who are not themselves in healthcare settings, if you are, you know, a consumer of healthcare, you know, you're just going to your doctor, your dentist or something, you can ask, hey, are you documenting this? Are you capturing that with patients? Why are you doing that? Stop doing it. Because we also have the power of providing pressure as consumers of health services and reminding, you know, organizations that may not have thought about this issue the way we have in the last 90 minutes. So please, 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 you know, use everything at your disposal.
Absolutely. Absolutely. 100%. And again, that's also that we can all play a positive role in this. And so I think, you know, the best way to fight fear and panic is to have something to do. And so one thing we're doing is calling our reps and saying, don't cut Medicaid right now. But another thing we're doing is going about our daily lives and thinking, okay, how would this be if I were an immigrant? And yeah, I think that's great, Steve. Challenging institutions that we're dealing with, like, why are you asking this? Like, I'm in a safe position to ask you why you're asking this, right? Like, I have no risk in asking you this question. And so I want to know why you're doing it. And we can all, you know, in the spirit of helping people do better, we can all participate in that. And again, also thinking, have we sometimes failed to protect other populations historically? And to own that and to say, this is not just about immigrants. This is me taking more responsibility for making sure that law enforcement follows the US Constitution for everyone. It makes everyone safer. And if I didn't think about this in this way before, I'm thinking about it now. And it's not that I want any one group to have more protection than another. It's that I want us all to be safe from over policing. And again, I think that is an important message to send, an important thing to really meaningfully do, because I don't like being in the position of thinking, oh, I'm protecting this group, and what have I done? What have I, Carrie Chapman, done sometimes when there was over policing before? Can you?
There are a few new questions in the open Q&A.
Oh yeah, and then can you go to? Oh, what legally can be done to prepare if the parents are deported? That's safety planning, Carmen. Oh, the anonymous attendee who talked about trackers. Boy, if you've got a tracker on you from ICE, I would say that's a difficult situation over which you're going to have limited control. If you have a tracker through a state charge or a local charge, that's a different story. Illinois is not cooperating right now with federal law enforcement. Oh, sorry, this is thanks so much for people putting resources in the chat. Please click on all those links, or maybe you guys can save the chat and share things out.
We will.
Asking for social security number is asking for status. It is for sure. Yes. I mean, it's complicated because those SSNs are used for other, like, helping you get Medicaid and other things. But anytime you don't need an SSN, don't get an SSN, right? Because it does leave you vulnerable to a subpoena for every, EMR that doesn't have an SSN, right? Like, don't put yourself in a troublesome situation. Sorry, my chat keeps like refreshing, and then
There's an interesting question about programs like HBIA, HBIS, which unfortunately the governor has announced that HBIA is being cut in the next fiscal year. So, but there will be information there because it's, in eligibility for it, it includes the fact that you're undocumented. Are there ways that we
for application, yes, but I don't know, as far as I understand it, the computer system at HFS sort of like doesn't parse things that finely. Like you can sort of get to that information, but it's sort of like eligible or not eligible. But yes, if people say, I don't want this anymore because I'm concerned about the state sharing this information with ICE, what I would say is that's a legitimate fear, but let's talk that through, or let me send you to somebody who can talk that through with you, because there are pluses and minuses, right? Like, and we can say, the law is very protective of this information. Illinois would never turn this information over without being required to. They would litigate having to turn over this information. There's a lot of protections there. And so think about the benefit to you as you also think about the risk. But then people have to make their own decisions, right? I'm not the arbiter of how much risk somebody is willing to take. That has to be the decision that they make, just like consent to healthcare, right? It's informed consent about what they want to enroll in and stay enrolled in. And I respect that. Are there best practices for warning patients in a space generally that ICE is on the premises? So that's one thing. If there's like a code, then, there's not going to be a ton you can do in a public space except try to move the ICE officer to have a discussion off to the side. But certainly in your private spaces, do you have a policy for what you do? Do you close doors? Do you whatever? Like, are there steps that you can take internally if ICE is on the premises? Can you show somebody out? Can you make sure that an exit is clear and show somebody out? And I think it's partially just operationally really thinking about like, what would we do and what would work? If I shows up and
can I ask?
Oh yeah.
If I can interrupt for a sec, you could also call the person back into the private, if while the clerk is trying to do that, you can just say, come on back with me, your doctor's ready for you, and bring them back. Does opening the door, now I have a question though, does opening the door, if my nurse opens the door to bring a patient in or for a patient leaving, that is still not, they cannot walk through that door. It is, okay.
No, no, no. As long
Super
as
important.
entrance to that door is monitored, like you can't, they can't just walk in. I couldn't walk in.
That's true,
So
yeah.
here's the question. If Carrie could just walk in, then ICE can just walk in.
Got it.
If Carrie can't just walk in, then ICE can't just walk in. So if you're taking somebody back, your doctor's ready, we walk out, don't holler their name. You
Right.
walk out, you go up to the person, you say, your doctor's ready for you, let's go back. And that the door that you go through is not publicly, a publicly open door,
Right.
then that person is protected then. Now, if ICE has a warrant, ICE has a warrant.
Yeah.
If ICE shows up and has an actual warrant, is it possible to insist that a patient at least get the rest of their care before they are arrested? I would certainly try to negotiate that. I don't have an answer as to legally how much you can require them to let the treatment go on. That I don't know, and I can try to look that up for you. But I would sure as heck try to say, like, this patient isn't stable, like I need to do X, Y, and Z, because they've certainly got the discretion. Any updates or concerns about DACA recipients? I don't really have any updates. I mean, so DACA has always been a risk. DACA is not status. It is deferred action. So it's basically you saying to the federal government, I am undocumented and here's where I live, but you're not going to deport me because I meet these criteria. So it's always been identifying your status to ICE and your location. And there's always been a risk in that as a practical matter. And there continues to be a risk in that. I think the question about the risk of DACA recipients, honestly, is a political question. How much would it hurt the administration to go after DACA? How many people will they lose if they start deporting DACA recipients? I think right now there is very broad support, particularly in pro-administration immigrant communities for DACA. But that is, a political question, I think, more than a legal question. But you cannot get DACA now. There are lawsuits ongoing about previous attempts to repeal DACA. It is sort of an ongoing litigation question, but kind of conceptually, is there a risk of, yes. But currently there's not a plan to start deporting people with DACA. There's not been an EO about that.
Okay, I'm going to ask people, I'm hoping that you've been thinking about one or two things, one or two actions you will be able to take as a result of this. If you are still stumped by that, what you might do tomorrow morning or next week, please let us know. We'd be happy to send you. I believe we have a survey that'll go out to all the participants asking, hey, what are you planning to do here? Are there any other questions? We're coming up towards the end. I don't want to make, push everyone's time, but.
This is Mildred. There is a question in the Q&A, and it's, do you have any advice to share for medical students who want to advocate for patients at student-run immigrant refugee clinics in South Texas, but might be scared of repercussions from either their school or elsewhere?
So what I would say, honestly, is get yourself hooked up with friendly free lawyers in Texas.
And discreetly hand out know your rights cards.
For sure, for sure.
That's something you can hand over without anybody knowing that anything just transacted.
Right. But I think there's definitely things that you can do. So it's just a question of knowing them, but exactly what the rules are at different schools. And for doctors in Texas, they have to follow the Constitution, but I don't know anything about it. So I would say get connected with legal aid who probably can't answer your question, but who knows who can, and get you some free, get yourself some free legal advice about what to do. Because they're definitely friendly people who want to give you that advice.
A recording has been made and will be available. I believe it will be secured. I don't know about capacity to share that with others, because obviously we are also being somewhat protective and defensive, as I said, at the jump, but we want to make sure that everyone is protected on this as well. LULAC for Texas is a great idea for our Texas medical student, is a terrific idea, but there will be a recording available to participants in this who've been on today. We could throw the poll up if I think if we can put it into the chat now so that people can launch it. I think even just getting that anonymous polling data is a great way to close this out. If we can put it up.
Oh, and one thing I'll say really quick while the poll's going up about HBA and HBIS, and Andrea will scold me for not saying it sooner, which is that not everybody in those programs doesn't have status. I mean, increasingly the folks left in those programs don't have status, but not everybody in those programs is currently deportable. So that's also important to understand. Again, it's very personal how much your risk is.
The 157 people still with us, that action step poll is on the screen. And so how will you take action? And you can check off whatever ones are steps you feel you can take. And we'll summarize that, I hope, in a moment. All right. I want to take this moment while you're all voting to thank Carrie Chapman, Commissioner Alma Naya, who had to sign off early, our organizers of this event, who just did an amazing job, including Mildred Williamson, who has been on the screen for this, our policy director, Wesley Epplin, Jim Bloyd, Sue Avila, Leandra Carlisle, and our two interpreters. This is a conversation that has been, in some ways a lot focused on playing defense. I'm going to wrap this with a quote from one of the organizers who inspires me, the late Grace Lee Boggs from Detroit, who said that every crisis, actual or impending, is an opportunity to envision a different world and a different opportunity for what the future might be like. So this isn't just about the stories that we're telling ourselves now. This is about what our future could look like. So hopefully people are beginning to think about an alternative. Our action steps are up. I see a lot of people sharing resources, talking with coworkers, excellent, talking to their employer and organization about what's going on and what's available, bringing this up at committees, excellent stuff, people. Let's build community for the world we want to see. Thanks everyone who participated this evening.